Imagine you are paying for medical care every single month inside a system that a different kind of physician, trained at a school that no longer exists, already knew how to provide differently. Not worse, not less rigorously, differently. Then one report, written by a man who had never practiced medicine, funded by Carnegie and Rockefeller, arrived in 1910. Within a decade, more than half of America's medical schools were gone. The system that replaced them had a gate on it. The gate is called a license. It has been controlling who gets to heal and who gets to pay ever since. Before 1910, American medicine was not a single thing. It was an argument. Competing traditions trained competing physicians inside competing institutions, and patients chose between them the way patients in any open market choose, by outcome, by proximity, by cost, and by trust. The country had 160 medical schools operating across every region. Some were attached to universities. Many were proprietary, owned and operated by practicing physicians who charged tuition, covered their costs, and sent graduates into communities that needed them. Some were homeopathic colleges, operating on a therapeutic tradition that had significant patient followings across Europe and the United States. Some were eclectic schools, drawing on botanical and naturopathic approaches that predated the germ theory era. All of them were producing practicing physicians. All of them were filling a genuine gap in a country where the demand for medical care far exceeded the supply of anyone trained to provide it. The geographic distribution of those schools mattered in ways that the reformers who came later either did not understand or chose not to address. Regional proprietary schools existed precisely because the populations they served could not travel to Philadelphia or Baltimore or New York to receive care. A school in Louisville or Memphis or New Orleans trained physicians who stayed in Louisville, Memphis, and New Orleans, and in the counties surrounding those cities, and in the rural communities that had no other source of medical attention. The system was decentralized by design because the country it served was decentralized by necessity. This was not a golden age. There were genuinely inadequate institutions. There were schools with no laboratories, no clinical training, no standards worth the name. The American Medical Association's own Council on Medical Education had begun rating medical schools in 1905, 5 years before the Flexner Report was published, and had classified a significant portion of them as deficient. The problems were real. What matters, and what the conventional history of this period consistently obscures, is who decided what the solution would look like, and who paid for that decision. Abraham Flexner was born in Louisville, Kentucky, in 1866. He attended Johns Hopkins University, graduated in 1886, returned to Louisville, and ran a private preparatory school for nearly 2 decades. He had no medical degree. He had no scientific training beyond his undergraduate coursework. He had never treated a patient, never administered a drug, never performed a procedure of any kind. In 1908, the Carnegie Foundation for the Advancement of Teaching hired him to conduct a survey of American medical education. He was 42 years old. The qualification that recommended him, by his own account, was that he had written a previous report on American universities that the Carnegie Foundation had found useful. Carnegie did not fund the medical education survey alone. The General Education Board, which John D. Rockefeller had established in 1902, and which by 1910 had already committed hundreds of millions of dollars to reshaping American educational institutions, was the deeper financial architecture behind the effort. The General Education Board's investment in medical education reform was not philanthropic in the detached sense. Rockefeller's Standard Oil fortune had by 1910 begun its transformation into a pharmaceutical and petrochemical industrial base. The alignment between a reformed, standardized, laboratory-oriented medical curriculum and the commercial interests of a pharmaceutical industry selling products derived from petrochemical synthesis was not incidental. It was structural. Flexner spent 18 months visiting 155 medical schools across the United States and Canada. At many institutions, he spent a single afternoon. He examined facilities, reviewed curricula, assessed laboratory equipment, and interviewed faculty. He had no clinical basis for evaluating patient outcomes, no epidemiological framework for assessing which therapeutic traditions actually worked, and no comparative data on graduate performance. What he had was a template, the Johns Hopkins model of medical education, laboratory-based, research-oriented, requiring 2 years of pre-medical science before clinical training began. Johns Hopkins was the standard against which everything else was measured. It was also the institution most aligned with the curricular priorities of a pharmaceutical-era medicine. The report Flexner published in 1910 was called Medical Education in the United States and Canada. It was direct, confident, and devastating in its assessments. Schools without adequate laboratories were condemned. Schools without hospital affiliations were condemned. Schools whose faculty were primarily practitioners rather than researchers were condemned. The language was the language of scientific objectivity. The conclusion was that American medical education needed immediate, radical consolidation. The report did not recommend which schools should close. It did not need to. The state licensing boards that controlled medical practice in every state were already watching. And the AMA's Council on Medical Education, which had conducted its own classification 5 years earlier, had already reached its double conclusions. The Flexner Report gave those conclusions the external authority of an independent scientific survey. It provided political cover for a result that had already been determined. The mechanism by which the Flexner Report translated into mass school closures was not a federal mandate. There was no law passed in Congress, no executive order, no single administrative act that shuttered 94 medical schools. The mechanism was more precise and more durable than any of those. It was the licensing board. Every state controlled the right to practice medicine within its borders through a licensing examination. To sit for that examination, a candidate needed to have graduated from an approved medical school. Approval was granted by the state board. State boards, in the years immediately following 1910, began adopting the Flexner Report standards as the basis for their approval criteria. A school that could not demonstrate adequate laboratory facilities, a full-time research faculty, hospital affiliations, and a 2-year pre-medical science requirement could not achieve approved status. A school without approved status could not place its graduates into licensure. A school whose graduates could not obtain licenses had no students. A school with no students had no tuition. A school with no tuition had no operating budget. It closed. The capital requirements embedded in the new standards were not incidental. They were the point. A fully equipped laboratory, a hospital affiliation, a research faculty drawing salaries rather than splitting clinical fees. These things cost money that a proprietary school run by practicing physicians could not generate from tuition alone. The schools that survived were the schools that could attract philanthropic endowments or university subsidies. The schools that attracted philanthropic endowments were, with very few exceptions, the schools whose curricular orientation already aligned with the priorities of the foundations providing those endowments. The loop was not complicated. Carnegie and Rockefeller funded the report. The report set the standards. The standards required capital. The capital came from Carnegie and Rockefeller-aligned institutions. The institutions that received that capital trained physicians in a curriculum oriented toward pharmaceutical therapeutics. The pharmaceutical industry that benefited from that curriculum was capitalized by the same industrial fortunes that had funded the report in the first place. This is the fuller version of events that the conventional history of the Flexner era does not tell. The conventional version is accurate as far as it goes. There were genuinely bad schools. Standards were genuinely needed. Flexner was genuinely appalled by what he found at the worst institutions. All of that is true. The fuller version requires understanding that the solution chosen was not the only possible solution, that the standards adopted were not the only possible standards, and that the financial interests of the people who funded the reform effort were served, with extraordinary precision, by the specific shape the reform took. No population absorbed the consequences of that shape more completely than Black Americans. In 1910, there were 7 medical schools in the United States that trained Black physicians. They existed because the mainstream medical schools of the era did not admit Black students. They served a community that had no other pathway into medical practice and no other institutional source of physician care. The Flexner Report evaluated all 7. It recommended the closure of 5. By 1923, only 2 remained: Howard University College of Medicine in Washington and Meharry Medical College in Nashville. The other 5, including Louisville National Medical College, the Flint Medical College in North Carolina, the Medical Department of New Orleans University, and others, were gone. Flexner's own language about several of these institutions and about the populations they were meant to serve was not neutral. In his report, he wrote that the black physician's function was to serve his own people, and suggested that training should be oriented toward public health and hygiene rather than the full scope of medical practice. The sentence requires no editorial comment. It describes its own logic with complete clarity. The arithmetic of what followed is not abstract. 5 black medical schools closed. The 2 that survived produced a combined graduating class that could not begin to meet the physician needs of a black population of roughly 10 million people in 1920. The rural counties of the South, where the majority of that population lived, entered a physician shortage from which many of them have never recovered. The communities that lost their regional medical schools in the consolidation era, black and white alike, rural and working class alike, did not get better medicine from the institutions that replaced the schools that served them. In most cases, they got no medicine at all. By 1935, the United States had 66 approved medical schools, down from 160 in 1910. The physician-to-population ratio had dropped sharply. The schools that remained were concentrated in the urban Northeast and Midwest, in university settings, producing graduates oriented toward hospital-based, laboratory-confirmed, pharmaceutical-supported practice. The gate had been built, the license was running, and the industry waiting on the other side of that gate was already counting its returns. The American healthcare market in the years following consolidation began its long climb toward the number it occupies today, $4.5 trillion in annual expenditure, the largest healthcare market in the history of human civilization. $4.5 trillion. That is the annual revenue of the American healthcare system today. Not its budget, not its cost estimate, its revenue, the money that flows every year from patients and employers and governments into a system whose fundamental architecture was designed in the decade after 1910 and whose relationship to the people it serves has changed less than almost any other major industry in the past century. You cannot negotiate with your hospital system. You cannot choose a competing physician network in most markets. You cannot opt out except by foregoing care entirely, which until very recently was the only alternative available to the majority of Americans who found the system's prices incompatible with their incomes. The institutional actors who govern that system today are not hidden. They are publicly named, publicly traded, and publicly defended. The American Medical Association controls the credentialing standards that determine who may practice medicine. The Association of American Medical Colleges controls the accreditation of medical schools, and, through that accreditation, the annual supply of new physicians entering the market. The major hospital systems, HCA Healthcare, Common Spirit, Ascension, Tenet, control the physical infrastructure through which the majority of serious medical care is delivered. The pharmaceutical companies that supply the therapeutic inputs those hospitals deploy are themselves among the most profitable enterprises in the American economy. And the institutional shareholders who hold dominant positions in the hospital systems, the pharmaceutical companies, the medical device manufacturers, and the insurance intermediaries that connect all of them, are, with a consistency that requires no conspiracy to explain, the same concentrated pools of capital: Vanguard, BlackRock, State Street. The circularity of interest that characterized the Rockefeller and Carnegie architecture of 1910 has not disappeared. It has become more abstract, more diffuse, and more legally insulated. But the underlying structure, in which the entities that set the standards also benefit from the revenue those standards protect, and also hold positions in the companies that supply the inputs those standards require, remains essentially intact. The regulation did not end the extraction. It institutionalized it. It made it orderly. It put a licensing process around it and called that process public health. The physician shortage that consolidation created is not a historical artifact. It is a present condition. The United States currently faces a projected shortage of up to 86,000 physicians by 2036, according to the Association of American Medical Colleges' own workforce projections. The counties most affected are the rural counties of the South and Midwest, the same counties whose regional medical schools were closed in the decade after 1910, the same counties that lost their locally trained physicians and never replaced them with anything comparable. The gate that was built in 1910 is still standing. the communities on the wrong side of it are still waiting. This pattern does not belong only to medicine. Edwin Howard Armstrong invented FM radio, a technology superior to AM broadcasting in nearly every technical dimension. He spent years in litigation against RCA, which controlled AM infrastructure, and which understood that FM's widespread adoption would render its existing investment commercially obsolete. Armstrong died by suicide in 1954. RCA paid a settlement to his widow that was a fraction of what his patents were worth. The technology was suppressed for decades. The infrastructure it would have replaced kept running. The pattern is not a coincidence. It is not a conspiracy. It is simply the behavior of incumbent financial power when it encounters a technology that would make its existing revenue model obsolete. In medicine, the equivalent of FM radio is currently taking several forms simultaneously. Direct primary care, a model in which physicians charge patients a flat monthly fee and bypass insurance billing entirely, is growing slowly in markets across the country and is being met with legislative resistance in states where insurance industry lobbying is strong. Nurse practitioners and certified nurse midwives, whose scope of practice expansion would meaningfully address the physician shortage in rural markets, face licensing board opposition in state after state, opposition that traces directly to AMA lobbying against any expansion of non-physician practice rights. Telemedicine, which briefly expanded under emergency pandemic waivers, has faced systematic regulatory rollback as those waivers expired and incumbent interests reasserted their positions. When a new delivery model threatens an existing revenue model, the existing revenue model fights back, using the legal and political tools available to it. This is not unique to medicine. It is how industrial incumbency works in every sector. In medicine, the stakes are simply higher, because medicine is not a consumer preference. It is not a luxury. It is the foundation of every other form of productive activity. The 160 schools that existed in 1910 were not all worth saving. Some of them deserved exactly the fate they received. But some of them were doing something that the system which replaced them has never done. Reaching the people the system was not built to reach, in the places the system was not built to serve, with the resources those places could actually sustain. Those schools were closed before the experiment could conclude. The decision to close them was made on financial and institutional grounds, not scientific ones. The communities they served were never asked. The alternatives were never tested. The gate came down, and the license began running. And what might have existed on the other side of a different set of choices has been waiting ever since in the records of demolished institutions and the physician deserts of counties that reform forgot. That is the story they never taught you in medical history class. If this video changed the way you think about who actually built the American healthcare system and why, share it with someone who needs to hear it. Subscribe for more revisionist economic history that follows the money back to where it actually goes. And tell me in the comments, do you think American medicine would look different today if the Flexner Report had never been written? Because that conversation is far from over.